Dr. Deven has joined.
Mm,
We are live now, doctor.
Hi. Good evening. Good evening. Thank you. Hello, everyone, and a warm welcome to every one of you for this GSI live webinar. Today we have two wonderful speakers, the masters, Dr. Sushmita Kaushik from PGA Chandigarh, and we have Dr. Sirisa Sendil from LVPI. Both of them, they don't need any specific introductions. Every one of us know both of them very well. So without much of delay, we will start the first talk from Dr. Sushmita. It is going to be on the OCT. We all see the colors, whether it is red, green, or yellow. But is that true that everything appears to be red as a red or green as a green? So today we have Dr. Sushmita to tell us on whether the red and green and yellow is okay or not. Over to you, Dr. Sushmita.
Thank you, Dr. Satyan and GSI for the opportunity. I'll just share the slides. Right, I hope that's visible.
It is, yes, you can go with the full page.
Okay, yeah, full screen?
Yes. Now we can see, we can hear you and we can see the slides as well.
Right, thank you. So I'll be talking today on looking beyond the colors of the OCT, because all of us who do any sort of practice in glaucoma, I'm sure are faced with patients who carry these colorful reports and a little bit of red and they'd be panicking and they'd come for second or even third opinions. And many times, unfortunately, they've been put on treatment because of the red on the OCT. So I thought it's important for us to take stock of the fact of what these colors are and whether to interpret them as glaucoma or normal or actually see the OCT for what it is telling us. So the learning objectives in the next couple of minutes would be to understand the fundamental principles of the OCT, to explain the colors on the OCT printout, and then possibly also discuss the significance. So starting with imaging for glaucoma, it's actually when you image the angles, you look for the cause. And if you image the optic nerve head, you actually see the effect of the raised pressure due to the obstruction in the angles. So it's actually seen first, the optic nerve, the what, and then you start looking for the why, and usually the gonioscopy comes later. So it's not as though we look for the cause first. We see that a disc is damaged, and then we go back and ask ourselves why the disc is damaged. So why is the optic nerve so precious? And the easy way to understand that, of course, is that it's a magic cable. It is a cable between the retinal ganglion cells, which collect pictures which are focused on the retina. Then they are transmitted, as it were, to the CPU, which is the brain. And once it is processed there, that is what finally results in sight. So it's this cable that is between the camera and the CPU that is so precious, and that the state of that cable is what we see when we do the OCT. So imaging burst upon the glaucoma scene almost 3 decades ago in the early 90s, where it was recognized that glaucoma was thought of as a continuum, and we've all seen Robert Weinreb's famous color-coded picture on that, where glaucoma is thought of as a continuum rather than a one-stage disease. And what really came upon the imaging scene was the acceptance that early changes may not be detected clinically. And then side by side, we also had imaging for the pathophysiology of the angle changes to be delineated better, more than possibly just a gonioscopy. So those were exciting times, and we were just opening our eyes into the world of glaucoma, most of us. And we've all read these early papers, mainly by Philip Medeiros and Robert Weinreb's group, where the OCT, the GDX, the HRT, and in our early days in glaucoma, we all had pros and cons, and we discussed and debated whether HRT is good or OCT is good or GDX is good. But over the period of time, and why I'm saying this and showing these papers is after this initial flurry of excitement, over a period of time, most other machines have sort of receded from clinical practice, but the OCT and the spectral domain OCT actually has held force. So that's why when we talk of imaging of the optic nerve head, we tend to assume it is only the OCT, but you must remember that there were many predecessors to it, and it's taken a lot of work before we have a semblance of understanding that we have today. So for me personally, and you can see this is about 3 decades ago, I think, with Dr. Pandav and me, with Professor Gupta, because the president came calling, and our center was just formed, and we were part of this, lucky to be part of these exciting times when so much of imaging came, and we had the opportunity to work for them. So those were happy days. And for most of us who's worked in glaucoma over the last 2 to 3 decades, the happy days happen when you can see there's the fundus camera, there's the HRT, there's the Stratus OCT, there's the UBM. So this is just to tell a journey that the condensation of what I'm going to tell you is just over understanding over years. And what I'm going to say today is not necessarily what is going to be the same maybe a couple of years or 5 years later. So the first thing was, when you have equipment and you have patients, is the questions that come. And then when you have these questions, you can actually answer them. So the questions are, what is normal for us? So we realized that the RNFL thickness in normal ocular hypertensive and glaucomatous eyes are actually less than what was published by Weinreb's group most frequently. So that's something to understand. It's important because these colors are representations of a normative database in the OCT machine. And the normative database is a very few hundred Caucasian eyes. So that itself should tell you that every red, if your population is a little thinner, may not be really red or really glaucomatous. So that's one of the first things to understand. Then the next is how reproducible it is from machine to machine, or rather from examination to examination, intra-test or inter-test, how reproducible it is. So that's the next thing we thought we'd see. And then it was pretty much, we realized that the reproducibility of the spectral domain was actually about 7 to 10 microns only. So anything, so that means that if you have a change of about 5 microns, don't get excited over it. I mean, an increase of 5 microns does not necessarily mean better, and a decrease doesn't necessarily mean progression. So those are things to understand, that you need to have reproducibility of the machine within how many microns, and how do you interpret change even if you see it. Then the third question, at that time, the OHTS had come out. And the biggest thing that we learned was thicker corneas are protected, and thicker corneas don't develop glaucoma as much as the others did. And that was one of the most protective things of the OHTs. So the question was, is it something to do with the RNFL? And we actually correlated both and realized that the central corneal thickness and the retinal nerve fiber layer thickness are correlated very well. So possibly it is both a thicker RNFL as well as a fallaciously possibly measured intraocular pressure, which may explain why those so-called higher pressures are better tolerated by these thicker nerves and thicker RNFL. Maybe the volume that is there, or the reserve that is there of the ganglion cells, is more. But that was just a thought that came, and we actually saw that it correlates very well. The Stratus OCT had a proportional protocol. For you youngsters, you won't know what it is. But when we started out with the OCT, we had a fixed protocol, which is 3.4 millimeters, which is what is there in all OCTs now. But we had something called a proportional scan, which meant that when you put that scan on the optic nerve head, 2.27 times that was the actual scan diameter. And where did this 2.27 come? Because an average optic nerve head was 1.5 millimeters, and the scan diameter of the fixed was 3.4 millimeters. So 3.4 divided by 1.5 is 2.27. So there was a scan protocol called 2.27x. So you were supposed to, for the larger discs and smaller discs, it was thought that you put your circle around the disc And then when you scan, the scan circle will be 2.27 times. When we looked at our fixed diameters and proportional scans, we realized that ultimately the retinal nerve fiber layer is coming from the center of the optic disc, and it is more reproducible and better if you have a fixed diameter protocol. And as it turns out, the subsequent OCT machines don't have anything called a proportional scan. So questions that come into your mind are very important when you're clinically dealing with any new equipment or anything that's coming. The other thing we wondered was, we have suspects, and those were the days when pre-perimetric glaucoma was a big thing. So we wondered whether, and frequency doubling perimeter had come in, we had the matrix. So the question was that, can we pick up pre-perimetric glaucoma? So if you have normal visual fields, which is what we had, we took patients with normal fields and suspicious discs, and then we did the OCT and we did FDT, and actually saw that the FDT correlated quite well with the RNFL thickness. So that was nice, and we followed that up with a progression of the disc suspects. And sure enough, when the FDT was worse and the RNFL was thinner, those disc suspects, as you could expect, went on to develop glaucoma over a period of time. There was another concept that trabeculectomy actually can reverse RNFL thickness. So what the postulation was at that time, and there were some papers that came out, said that it is possible that some retinal nerve fiber do not die or do not atrophy, and they're just smashed together, if you please, and if you reduce the pressure, they come back. So everything you have to question, and you have to try it out yourself. And then when we did the OCTs pre and post trabeculectomy, sure enough, the RNFL was thicker in the first 3 months, and then after 3 months, it would come back to exactly what it was. So I sort of tend to believe that it is the localized edema postoperatively, the inflammation, which possibly comes out as an artifact. Now remember, this would come out as a higher RNFL or a better color, but it doesn't mean that it is coming back. It is just anatomy. So that's the, and then of course we also published on solar retinopathies, where the OCT really showed us the photoreceptor loss that we could see. And many times that photoreceptor loss was lost because you didn't look at the macula at that time so much. We would, nowadays you have the GSI and you look at the macula every time. But in solar retinopathy, despite low vision, usually the RNFL would be normal. So then, of course, when the spectral domain OCT came, we had to see how do they compare, and they don't compare well at all. So there's no way that you can follow up a patient who has had baselines done on the Stratus. Of course, now that's redundant because Stratus hasn't been around for the last 10, 15 years at least. But at that time, we had both, and there were a lot of questions of whether you should use spectral domain or you should use the time domain. But anyway, that's a little redundant now. And then we looked at progression of both of them. And then came the GCA. So we looked at how important the GCA is, and we'll just come to examples of why you should do the GCA in addition to RNFL thickness in every glaucoma patient, and why that's enough. But when we evaluated that, we found that it was useful. And then, of course, we started working with children, and we realized that the visual field indices in children with comparable retinal nerve fiber layer thickness as to adults is much lower. So don't jump to a diagnosis of glaucoma until they're about 12 years old, because the sensitivity is simply not enough. Okay, so having given a background of what was known and how it was clinically applicable, I'll just give you one pearl to understand the OCT. And if it is that, the fundamental is this. So there's no question that this is glaucoma. There's a vertically oval disc here, and there's a vertically oval cup. There's bearing of the inferior circumlinear vessel, and there is a notch here. So there should be no ambiguity about the fact that this is certainly possibly glaucomatous. And if you see the visual fields of the right eye, you can see there's corresponding superior field defects, right? So what is the pearl? The pearl is that here we are, the ganglion cell. So you have compression at the lamina. There's exoplasmic stasis, and then you have ganglion cell loss here, which is visible as a temporal raphe. And when this ganglion cell is lost, this axonal atrophy starts happening, and that is seen as your red on the OCT. So let's quickly go over what these things mean. because it's important to understand that. After all, we're dealing with colors. So this is the thickness map, which only means that these colors are color-coded for anatomical thickness alone. It makes no difference to the OCT machine whether thinning is due to glaucoma, not due to glaucoma, whether thickening is due to papilledema or thickening is normal. It just gives you a color code for anatomical thickness of the retinal nerve fiber layer. So if you see here, the red means it's robust, it's thick, the yellow is a little thinner, and the blue is very thin. So you can see this is the normal distribution in the left eye. This is a normal distribution of the RNFL, where the superior temporal and inferior temporal have the thickest RNFL and the rest are blue. Whereas here, since it's blue, you can make out that there's RNFL loss, which is shown here. The next is a deviation map. So again, what do these colors mean? These colors mean very different things. Now here the red is good, it means thick, but this is a deviation map, which means like a visual field, how much does it deviate from normal? So a red here means more deviation. So don't go away with just colors. So a red here is thicker, but a red in the deviation map is compared to a normal, it is thinner, more thin than you would be expecting to see in a normal population. And if there's no deviation at all, like in this side, there's a little bit of yellow here, but by and large, the RNFL in this eye here is what you would expect in a normal population. So this is called the deviation map. This is a thickness map, this is a deviation map, right? And these, of course, are arbitrary quadrants. And as we go along, you'll see how meaningless these are, but they've just been, drawn like people draw lines across lands, isn't it, and divide people. So we've drawn lines across this and just divided the RNFL, but these are very arbitrary. And here you can see the legend for this. If in comparison to the normative database, it is likely to be less than 1% of them, it's flagged red. If it is likely to be between 1 and 5%, it's flagged yellow. If it's likely to be between 5 and 95%, it's flagged green. And if it's likely to be more than 95% of normal people, it's flagged white. Again, anatomical thickness in relation to what the machine has. Nowhere does it mean that red is glaucoma, green is normal, and white is abnormally thick. It doesn't mean that at all. So that's something to understand. And the same color coding, of course, comes again, arbitrary quadrant clock hours. So these are quadrants, these are clock hours, nothing to do with physiology, arbitrary lines drawn by people to just understand it better. So here you are. This is the ganglion cell loss, and which translates into the RNFL loss, and you can actually see the little bit of notch over here. So that's the pearl, the funda of the OCT. So we'll just take you across some real world examples. So this again should be a straightforward POAG. There's an RNFL defect there, there's a notch there, right? So there should be no ambiguity in that. So here you are, that's the RNFL defect. And here you have an inferotemporal field defect, nice and stable across the ear. So good, straightforward POAG, well-controlled, easy clinical patient to come. Now, this is the little thing. So you see this quadrantic map, because we have made these quadrants, the averaging out is equal to what it would be in the normative database. But there's a thin RNFL defect here, which is coming on to the clock hour, but not in the quadrant. It doesn't mean it's normal. It just means that this arbitrary thing has not come in. But you can see the deviation here is so red, and the thickness here is so blue. So there's no doubt about the fact that this is it. Now, if you see the ganglion cell layer here, it's absolutely fine. Remember, I said that there's ganglion cell which is lost, and then the axonal atrophy occurs. But here, it's an absolutely pristine ganglion cell analysis. Now, why is that so? Also, when they sold the machine with this, they would tell you that the GCA is important because it picks up RGC loss, which precedes RNFL loss. But here you see there is no ganglion cell loss, and yet it is. And there is an RNFL loss. So what happens is this ganglion cell is a fixed diameter scan, and the ganglion, because this is high up in the pole, the ganglion cells are lost somewhere here. So the ganglion cells are lost up there. It's just not in your measurement circle. It doesn't mean that there's no ganglion cell loss. If you had a large measurement circle, you would have caught the ganglion cell loss there. But the RNFL loss is so close to the poles that it is not reflecting in the ganglion cell layer, right? Now, so that's important, and it has come out in a paper which said the topographic profile of retinal nerve fiber layer affect the diagnostic performance of macular scans. So if you have an RNFL loss or a damage near the poles, your ganglion cell might be normal. Whereas if you have it closer to the papillomacular bundles, you can have normal RNFL, but your ganglion cells layer may be distorted or affected. So it has nothing to do with what comes first. It is to understand what your machine is measuring. So let's see another one. There's no question about this. Absolutely. You can even see on the fundus picture that this RNFL is really bad, and there must be a lot of loss there, whereas this seems a little better, isn't it? Sure enough, when you see the visual fields, quite a bit of moderate glaucoma. Most of this is gone. So this is again stable here. And this is earlier glaucoma, but central deep defects. And yet it's here, but then you would sort of go away thinking that, okay, this is early glaucoma, and this is moderate glaucoma, and this is the one which I have to take care of, right? So now you do your RNFL and look at this. Now your RNFL in the left eye is completely normal. And yet you can see there is bearing here. Now remember what I told you. You have loss nearer the papillomacular bundle, but it hasn't been picked up in these arbitrary lines which have been drawn on the OCT simply because the loss is not where this machine is measuring it. Now, once you do the ganglion cell analysis, in this one, it's scary. The left eye is as likely to go into blindness as the right eye. So the ganglion cell of both are nearly the same. Despite the fact that you would think that the VFI is so much better, look at where it is. It's nearly up to 100% there, whereas here it's gone down to 70%. But the deep central defects are likely to be very blinding. And be careful with these deep central defects in normal tension glaucoma, because there the defect is closer to the papillomacular bundle. So again, an illustration of the fact that the colors on the OCT of where they are don't matter as much as you understanding why that is happening. So again, these are examples. You can see these are early glaucomatous, very few, a little bit of a nasal step there. And here that is almost normal. Now, you would think that this is an RNFL defect. You have a nasal step. Everything has told you that pre-perimetric glaucoma picks up defects even before the visual fields. Here you have a nasal step on the visual field and an RNFL loss, and yet on the OCT, it's absolutely fine. Now, why is it not picking up on the OCT? Why doesn't it show up on the OCT at all? Now, look at the left eye. The left eye, which you think is normal, and look at the thickness map. You see how red it is. You see how thick it is. And then you see this on the other side. Even though it is red, but it's not as red as the other. And if you see the quadrant and the other maps, you see so many whites. So it's an inherently thick RNFL, but the thinning in the right eye, which you see clinically, which has caused a visual field defect, is not in the normative database or within the normative database thinning, and therefore the OCT is green. The OCT is green, but that color is not saying anything about what it is. And if you look closely now, here is that little bit of RNFL, which is beyond the measurement circle. So it's right down there. The measurement circle hasn't picked it up because the circle is just 3.4 mm, and this is flagged completely green. The clock hours on the OCT, like I said, are arbitrary. So if a clock hour bisects a very thin RNFL or an early RNFL defect, then it averages out and it might be within the so-called normative database of that machine, but it is not normal. So green is not normal unless you really look at the patient. Now look at this 57-year-old woman. This is a very, very favorite patient of mine because I keep showing this. So these are small discs and very, very easy to miss glaucoma. But if you see the disc and the cup to disc margin, you can see that the left eye is obviously bigger. And there is an inferior RNFL defect. This is nice and robust. There's a little bit of an inferior RNFL defect compared to this one. And if you see the fields, there's no question that there is early visual field defect occurring. But again, you see the OCT, it's completely normal. So again, it's not normal, sorry, it's green. Again, small disc, you can see how small the cups are. Small disc, small cups, thickened RNFL, crowded RNFL, you'll miss glaucoma very easily. Even a 0.5 cup in a small disc could be glaucomatous. So don't miss it for the green that the OCT machine shows you, right? So coming to this again, disc hemorrhage, larger cup, RNFL defect, visual field loss. Do you really need a machine to say anything? And yet, now this is a Stratus machine, and unfortunately the patient didn't come back, I think, for many years, but it's still normal. So the Stratus machine shows up the thick RNFL, but shows no RNFL defect. So if you have an acute disc hemorrhage, this is one small thing that we've picked up over time. If you have an acute disc hemorrhage, possibly there's extravasation around that area in the rim. And this OCT machine, you can see this little bump here. So this extravasation, the OCT thinks is anatomically thick, and it'll tell you that there's no glaucoma. Don't miss it. You can't miss a patient like this, no matter how green the OCT is. Now, this is another one, loss of vision in the left eye. Anybody would say it's a pale disc. There's RAPD. It's a small disc again, disc at risk. Disc at risk for glaucoma, disc at risk for AION, disc at risk for dysdrusen, for everything. Marked thinning on the OCT, not glaucoma. So this was non-arthritic AION. So any cause of thinning would be red on the OCT, but it's not glaucoma, right? So be very careful with small discs. The OCT can tell you that an obvious glaucoma is green, and the OCT can tell you that an obvious non-glaucoma is red as well. A disc suspect, it's a spotter on the visual field, bitemporal hemianopia. I like the OCT for this, even though this is Arbit, it doesn't say anything, but the GCA shows it up beautifully. So this is so nice that a bitemporal ganglion cell loss, or a binasal loss showing up as a bitemporal visual field defect. So it is, I think, important to do a ganglion cell and an RNFL in every patient of suspicious disc. But we would never have suspected it just on this. He was just a large disc and large cups until this showed up. So even for progression, remember OCT is a machine, don't go by colors. This was showing progression. 93, 99, 88, and finally this. But if you see the signal strength, it's just 5, and you repeat it on the same day with just a drop of viscoelastic in the tear substitute in the eye, and this so-called progression disappears on the same day. So don't look at colors and see for progression. If everything else is fine, ask yourself a question as, are we making a mistake? Sometimes it's red, but you may not be. She's been diagnosed glaucoma. She's one-eyed. She lost the other eye to an accident. Petrified. So she comes because this has come up red and she's on 3 drugs already. So remember this. This is a little bit of a Weiss's ring. And remember, if it's black, there is no measurement at all. So no measurement. You can see this. This is no measurement at all. And this is the Weiss's ring here. And PVD in elderly patient, if you see black on the OCT, that's another color not to miss. It means that nothing has been measured. So there it is. This is black and it's red because there is no measurement here, but it's within the circle, and therefore it's taken up as glaucoma, but it's not. It's taken up as red. Again, this was easy. Temporal pallor. You can see RNFL gone. You can see the GCC completely gone, red as well. But the RNFL is reasonable. But there's a paper on this that a progressive GCC loss always occurs before RNFL damage in Leber's hereditary optic neuropathy. So if you have temporal pallor and papillomacular bundle loss, GCA gone, but RNFL okay, think of a macular problem. The other thing is You can have similar things in toxic and nutritional deficiencies. We've seen it in alcoholics with vitamin B12 deficiency. The discs are really clinically quite unremarkable. If you just get away with an RNFL, you might think, I don't know why he's not seeing much. But if you do the GCA, you'll realize that the macula is completely gone. So be very careful in smokers and alcoholic. Look for B12s. And actually, if you just give them injectable B12 for a short course, they actually revert back and they do well if you catch them in time. Well, there is cupping here, referred as NTG. Again, sorry, there's an inferior RNFL loss. You can see it's completely blue. But despite that cupping, the GCA again gives clues. So a young man with cupping, RNFL unremarkable, but look at the GCA. Again, the loss in one quadrant. The HFA then shows you that it's a parietal tumor, which he was harboring, and he was going around as a glaucoma suspect for a couple of months now. So if you have cupping in the elderly, it's always a red herring. I know glaucoma happens in elderly, but this bit of temporal pallor should alert you. Again, a visual field which respects the vertical midline. Don't forget that it's a pituitary macroadenoma, and actually the visual fields revert and the OCT would be similar. So ganglion cell, these are just examples of how RNFLs were sort of all right, but ganglion cells actually gave us the clue. When shouldn't you not do it? If I have discs like this, I wouldn't do the OCT because the segmentation is so bad that is really something that we cannot interpret so well. Here, actually, the HRT, if you're lucky enough to have your machine still, the HRT is very useful because it maps the optic nerve head and you can follow it there. So in summary, I would say the approach to any patient depends on what it is. And what it is evident by sound clinical judgment. But if there's one message here, red on imaging is not glaucoma. Glaucoma, non-glaucomatous cup disc, bad scans, all of them can become red. And green on imaging is not always normal, right? So imaging the angle and anterior chamber gives you more informed choices of management also. And technology, the more you see it, the more you'll use it as an ally rather than a master. And you can't use them in isolation. So thank you once again, GSI. Here are some references for the youngsters to see, but they've helped me throughout these years. And thank you, Dr. Satyan, again. Thanks a lot.
Thank you. Wonderful, Sushmita. I think you have kept your word. Thank you so much for a wonderful talk.
Yeah.
And as we have a little shorter time, we'll go with Dr. Sirisha's talk on the blebitis. We all do trabeculectomy. Is that a safe trabeculectomy we all do, or we all do think that we are doing very safe trabeculectomies, but sometimes in a very rare occasions, we may come across this blebitis. So how do we really identify the blebitis, and how do we really manage the blebitis in patients with post-trabeculectomy eyes? Over to you, Sirisha.
Yeah. Yeah, I hope you're able to see the slides and hear me as well.
Yes, both.
Yeah, fantastic. So, like Satyan said, I think this is one topic that all of us fear, and sometimes we are lost when we see a patient like this. And trabeculectomy is there, and several years ago, whatever procedures were done, and patients going around with thin cystic blebs are always at risk of developing an infection. So I just take you through a couple of cases. Let's say if somebody presents to the emergency with a red eye and vision is good, and this was the same vision that the patient had, and the pressures are well controlled. So it's easy to say that, it's nothing to worry about. It's okay. Just use some lubricants and come back. But there are subtle signs when they present to the emergency as to what is a bleb that is something that we need to be worried about, or what is it that we can say it's okay to come back after a month or after 2 months. So this is a young gentleman who presented to, in fact, he used to live in the US. And when he relocated to India, he came for an eye checkup. And the checkup was done, everything was fine. This was just a let's say, preventive checkup that he had come for. And just a day after his checkup, he presented to the emergency with this kind of a picture. His vision from 2020 had dropped to hand motions in just one day. The previous day he's had an evaluation and he was perfectly all right. The next day he came to the emergency in the morning with hand motions vision. What had happened between the previous day to this day was a small change, that when he went back home, he had some irritation in the eye. So he had some lubricants at home and he just opened the bottle and used the lubricants. And apparently the bottle was, I think, opened up 6 months ago or 1 year ago. And since there was some lubricant in that, he just went ahead and used it. And the next day he presented with this kind of a picture. So what is very important for us is, it's important for us to understand which stage of infection is there. Is there just the bleb that is affected, or is there an intraocular infection as well? So what is blebitis? What is bleb-related endophthalmitis? How do we recognize it, and how to treat, and most importantly also to prevent? Let's look at the infections that occur intraocularly. The commonest surgery that we do intraocularly is a cataract surgery, and typically every other endophthalmitis is possibly tried to compare with the post-cataract surgery endophthalmitis. So with that as the benchmark, the risk of trabeculectomy, the endophthalmitis following trabeculectomy, is far higher, and that after an augmented trabeculectomy with an antimetabolite is far higher. You can see if the high upper limit of post-cataract surgery endophthalmitis is 0.71, and upper limit here is 13.8%, which is quite high. So there are studies that have looked at early endophthalmitis post-glaucoma surgery. This was one such very large study that looked at more than 4.6 lakh glaucoma surgeries over a 4-year duration. And what did they find? They found that incidence of endophthalmitis was far higher after glaucoma surgeries compared to cataract surgery, and it was far higher when there was a tube shunt surgery compared to trabeculectomy. So I'm just leaving that aside, but remember that even the tube shunts can have endophthalmitis. The median onset of endophthalmitis was 1 to 2 weeks after the primary surgery. That means this is something that is very important. So it's not like, unlike the cataract surgery where they may present with an acute endophthalmitis, can present at second or third day itself. Here, these patients actually presented with endophthalmitis 1 to 2 weeks later. So that is very important, because I'll come to this point that when somebody asks for a glaucoma surgery in the second eye, let's say within a week or 2 weeks, I would be very scared, and I would say that I would actually want to wait at least for 2 to 3 weeks before I touch your contralateral eye. So I think that is important. Risk factors that they noted were increasing age, that means older patients, and if somebody had medical comorbidities like diabetes and things like that, and of course, male gender. So there was a very interesting study from Japan where they called it as a collaborative bleb-related infection incidence and treatment study, where they looked at the incidence as well as how the response to treatment were. And in the risk factors that they actually evaluated, they found that patients with bleb leak had a far higher chance of developing a blebitis or a bleb-related endophthalmitis. And it's also important to note that use of mitomycin C definitely increases the risk of infection. And with the wider area application and a shorter duration that we use, obviously the infection is far less because the bleb morphology is much better. If the blebs are very thin or if they are leaky, they have a problem. And if there is a longer duration of use of mitomycin C or a localized application of mitomycin C, there is a far higher risk of developing a endophthalmitis or blebitis. This can be present as an early postoperative infection or in the late postoperative period as well. So I'll take you through what the bleb-related infections look like and what is the spectrum. Sometimes you just have a bleb-related inflammation. That means there is an injected bleb without any mucopurulent infiltrate and without any evidence of inflammation in the anterior chamber or in the vitreous. That is like how the first picture is. Then is blebitis, where there is infection of the bleb, which is limited to the bleb. It can be associated with mucopurulent discharge. Sometimes there could be an AC inflammation, but typically no vitreous involvement. And bleb-related endophthalmitis is if you have an infection of the bleb, and of course the infection has spread into the both anterior chamber and into the posterior segment, and that is bleb-related endophthalmitis. The risk factors for blebitis and bleb-related endophthalmitis start from the lids onwards. So if you say blepharitis, conjunctivitis, nasolacrimal duct obstruction, a very, very important reason for blebitis. And this is something that we always should remember, that whenever a patient presents with blebitis or bleb-related endophthalmitis, like somebody presenting with a corneal ulcer, how it is so important to check for whether the sac is involved or not. It's very important for us to check the sac as well, because once we see the blebitis or bleb-related endophthalmitis, we are kind of worried and we rush to starting the treatment. But I think it's important to look at the risk factors, because unless we treat that, we may not be able to appropriately manage the patient. Thin cystic blebs, leaking blebs are more commonly infected. If there are releasable sutures but not released, and you have a loose suture hanging on the cornea or closer to the bleb, that could be a source of infection. Younger patients, especially children, are more prone to infection. And use of antimetabolites and inferior blebs are very, very high chance of infection. That's one of the reasons why none of us do an inferior trabeculectomy. Of course, implants are sometimes done, but even implants, even though a well-done implant, at a later time point, the chances of erosion and infections are far common if for an inferior surgery compared to superior surgery, where the superiorly the bleb, the lid, upper lid actually acts as a protection. So the biggest risk factor of all that was studied or that has come out is the bleb leak. Presence of a bleb leak is, of course, most important risk factor. How do you stage bleb-related infection? So if there is just a bleb involvement alone, it is stage 1. If there is involvement of the bleb that with an infection and presence of an anterior chamber involvement, then that is stage 2. Presence of the anterior segment as well as the posterior segment involvement is stage 3. And even in stage 3, it's further classified into stage 3A and 3B. Why it is important to know this staging is because the treatment actually depends upon these stages. While we see an blebitis, often we may not be there in an institutional setup where you have to just refer the patient to your VR surgeon and they will take care. But I think emergency management, and of course, if you are individual practitioners or if you are in a place where the patient is going to take time, 2-3 days time for them to reach the nearby institute, we should know how to manage the infection. So does blebitis occur only when there is a leaking bleb? Not necessarily so. So sometimes the infection can also occur by certain virulent organisms which can actually penetrate even intact conjunctiva. So in the presence of a bleb leak or a very thin cystic bleb, of course, infection is more common because there is any problem on the surface or any lid related problems also, even sometimes even commensals can actually cause an infection. But if there is a virulent organism, even in the presence of intact bleb, there can be infection as well. So when they present with redness, sensitivity to light, sometimes there is blurry vision and pain, but even in earlier than that, they may not present with, they just present with redness and some pain, but the vision may not be very much affected in the early stages. Typically, what we see is a white on red appearance. That means the conjunctiva is terribly congested and you see this bleb which appears as if it is a white opalescent bleb. It is very important to note that this thin bleb that was thin and cystic earlier was transparent or translucent is now become opaque. You don't see the underlying suture or underlying sclera. if you see an opaque bleb, always suspect that there is some problem. They can be associated with hypotony or high IOP, and you may see an anterior chamber reaction as well. Commonest organisms that cause blebitis or bleb-related endophthalmitis. So you can possibly divide them into early and late. Early typically are, like we discussed, in the presence of a lid infection or in the presence of a sac infection, it is more commonly, it commonly occurs. Late onset can be because of Streptococcus species or Haemophilus influenza. So we need to remember that the surface has to be treated before we take any patient up for a trabeculectomy. So we always have to make sure that there is no blepharitis and there is no other surface related problem, or in those patients with severe ocular surface disease, that needs to be treated earlier than taking it up for trabeculectomy. So when you see blebitis, that's what, so the bottom picture, the panel, the picture that is there is a transparent or a translucent bleb through which you can actually see the underlying sclera. And that is how we normally, the thin cystic bleb looks like. But just look at the upper panel, the same thin cystic bleb is infected and you don't see it. It's not transparent anymore. It is opaque and a lot of discharge is present. And if we check for seedles, we may also see a seedal spot positivity. Whereas the bleb-related endophthalmitis, we see there is an increased AC reaction and you can have vitreous involvement as well. So it's very important for us to, even if we are able to visualize the fundus, we should do a B scan to understand the echogenicity, because later on when we are following it up, when we are treating, even for us to know whether there is an intraocular spread or not, B scan will help you. So at baseline, it's very important to do a ultrasound B scan as well. So conjunctival swab is something that we should take and send it for culture sensitivity, and the grams and GMSA stain as well, and also do an aqueous tap or a vitreous tap based on the intraocular involvement. And of course, B-scan ultrasound is something that is very important, not just to know the vitreous involvement, but is there an associated choroidal detachment or a retinal detachment? How do we treat it? We need to first of all appropriately diagnose it, understand the staging. Is it stage 1? That means just the bleb being involved. Stage 2, where the bleb with the anterior chamber is involved. And stage 3, where there is an involvement of the vitreous. And stage 3 is further divided into A and B. So broadly, ocular and systemic treatment. Ocular treatment is we start them on broad spectrum antibiotics. The fortified ceftazidime is what we normally use. And of course, we also add the 4th generation fluoroquinolones as well. So usually we start off treatment every 30 to 60 minutes to begin with on day 1. And we see the response, evaluate the response to treatment. And we keep a watch on whether the inflammation is increasing or if there is an anterior chamber inflammation that is developing newly or not. And of course, we put them on aquasuppressants if there is a bleb leak and cycloplegic. Steroids should be very, very wary to begin with. Until and unless we get the culture sensitivity or the smear report, we should not be starting off steroids. And one needs to be careful. So systemic medications, we do give oral antibiotics, broad spectrum. And sometimes intravenous antibiotics may be necessary depending upon whether the patient has any signs of toxicity or not. And if we are suspecting an intraocular spread, or if the patient is one-eyed or immunocompromised, even in the presence of stage 1 or stage 2 infection, also systemic antibiotics can be started. So stage 1 or just the blebitis, like I just mentioned, topical fluoroquinolones and topical ceftazidime 1 hourly. Antibiotic ointment at bedtime can sometimes help. And sometimes subconjunctival antibiotics can also be given if for whatever reason the patient is not able to use the medications appropriately, or if there's no help back home. Antibiotic and micro report is something that we should always check for. If there is an anterior chamber involvement, intracameral injection can also be given apart from whatever else that we just mentioned. B-scan ultrasound is very important to look for any echoes in the vitreous cavity. Stage 3 is presence of blebitis or endophthalmitis, like I said, but again, stage 3 is, so the vitreous haze itself is divided into 5 stages. So we don't go into the details of this, but what is basically said is that if the vitreous is very hazy and disc and the vessels are hazily seen, it is until that is stage 3. But if you have very, very hazy vitreous and you don't see any other retinal details, that is stage 4 or stage 5. So if you have a stage 3A, intravitreal antibiotics are given and patient is not, that means if you are able to see some amount of disc and blood vessels, so it's only intravitreal antibiotics and they don't go in for a vitrectomy straight away. And of course, oral fluoroquinolones are also given and topical and intracameral are given as well. We always have to look for how the response to treatment is the haze worsening or not, based on which if there is an improvement noted and if the haze is not worsening or it is improving, then we can repeat the antibiotic. By then the culture sensitivity report would have come as well. If there is a stage 3B, that means if there is an involvement of the vitreous, but it is very hazy, or that is you can't see the disc also, or if there is, if the disc was visible the previous day or couple of days before, but the infection is worsening, then we go ahead with a vitrectomy. And intravitreal antibiotics are also given and oral antibiotics are also given. So just to recap, stage 1, it is topical antibiotics. Stage 2, it is topical and intracameral, and stage 3A is intravitreal antibiotics along with oral, and stage 3B is pars plana vitrectomy with intraocular antibiotics and oral antibiotics. We also have to remember that intraocular pressure can vary. Either it can be too low in the presence of a bleb leak, or once the infection resolves, the bleb can scar and the pressures can shoot up really high. So we also have to manage the intraocular pressures if they go up in these patients. Blood management, like I said, if there is a leak, we obviously don't repair the leak in the presence of an infection. We wait for the infection to resolve before we treat it. So aqueous suppressants can be given in the presence of an infection and a leak in the beginning. And once the infection resolves, we can go ahead and do a bleb repair. The visual outcomes, it depends upon when we catch the infection. If we catch it early and treat it appropriately, we will be able to retain the visual function of the patient. Otherwise, it can be very, very difficult to treat and the visual outcomes can be poor. So late onset bleb-related infection, pre-existing advanced glaucoma, poor initial visual acuity, more virulent organism, and delay in diagnosis, and of course, antimicrobial resistance are factors associated with poor visual outcome. So I'll just take you through examples of a few cases. So 70-year-old gentleman with POAG, repeat trabeculectomy done. He developed a bleb-related infection and a bleb leak. So if you see, that was a suture infiltrate and that has actually gone on to the bleb as well. And he also had a leak and CD as well. This was treated conservatively. The suture was removed, sent for culture sensitivity, and treated with topical and intracameral antibiotics. The leak resolved and the infection completely resolved, and CD also resolved, fortunately. Late onset blebitis, this is something that is difficult to treat, but if you are very aggressive in treatment, we will be able to salvage the eye. So the infection completely resolved in this patient. And there was thin cystic bleb with a leak. And of course, this needed to be treated with a conjunctival autograft. And once the conjunctival autograft was well taken up, you can actually see 2 months post bleb repair, a well integrated graft, and pressures were also maintained at 10 millimeters of mercury. Bleb-related endophthalmitis, wait for the infection to completely resolve before we go and repair the bleb. But once there is an infection, whether it is blebitis or endophthalmitis, even if we have appropriately treated the infection, it is important to go ahead and treat that bleb, because the chance of them having a recurrent infection are very, very high. We are not always fortunate. Sometimes if it is a difficult organism or if we detect it late, we may lose the eye. So to summarize, incidence of infection following glaucoma surgeries are far higher compared to cataract extraction. Tube shunts and mitomycin augmented trabeculectomies have a higher risk, and the rest of the risk factors, as we just mentioned. Bleb leak and thin cystic blebs are, of course, of more risk compared to the other risk factors that we see. So older patients are more commonly affected. Presence of ocular surface disease or lid-related infections can predispose them to blebitis and bleb-related endophthalmitis. Like I just mentioned, to reiterate, these infections can present as late as 2 or 3 weeks post-trabeculectomy also. So in case a second eye surgery is required, unless there is an emergency of very high IOP, not getting controlled and things like that, it's a different issue. Otherwise, always try and defer it for 2 or 3 weeks before we take up the second eye for surgery. And late onset disease is more common and it is more difficult as well. So early detection and treatment of infection is primarily what we need to do, and that is most important. Once that resolves, the bleb leak has to be managed. Even in the absence of a bleb leak, if there is a thin cystic bleb, that needs to be repaired. And of course, remember to manage the intraocular pressure as well. Thank you.
Thank you so much, Shirisha. Wonderful talk again. So it is very practical, and it is not that we don't see the bleb-related endophthalmitis. And it is not only for the glaucoma people to take care. So even the other, general ophthalmologist, you do see this bleb-related endophthalmitis. So it is important that if we can really catch up these patients as early as like the stage 1, if we can treat them, it is always better. They will definitely will recover. But if you feel you cannot manage with the stage 2, 3, 4, or 3A, B, then I think it is better you should refer these patients as quickly as possible so that still they have quite a good visual potential to have. So bleb-related endophthalmitis in a trabeculectomy eyes who has undergone with the mitomycin has to be kept in mind. And the interesting thing is, as soon as you see and then treat, once the infection is over, and if you feel the bleb is too thin, how soon they can go for bleb revision, Sirisha? Because
Yeah,
they have a very high chance of again reinfections sooner.
Correct. So if in the absence, so I keep asking this question to our VR surgeons. So in the absence of a leak, if it is a thin cystic bleb and it resolved and there is no leak now, I think we wait for a month before we go and repair. So if there is a leak, and that is a situation where we have to be a little bit, you have to intervene a little early. So once the infection completely resolves, they ask us to wait at least for 1 to 2 weeks before we go and repair the bleb.
Okay.
When I say completely resolve is they continue the antibiotic. So it is 1 hourly and then you taper it to 2 hourly. And not taper it, you bring it down to 2 hourly. And then as like always, antibiotics are never tapered. It is given until that high dose and then they are stopped. So it's 1 hourly, then 6 times, then we go down to 4 times. 4 times is continued. And of course, by then, if you get your culture sensitivity based on that, if the organism is different or if there is a resistance, of course, you keep changing the medication and then you treat it. Once it completely resolves, there is no inflammation anymore, everything is fine, then we continue the antibiotic for 1 more week, then stop, then go ahead and do the bleb repair. This is what we follow, but I'm sure there are places.
There is always a little bit of plus or minus the time delays. But is that every patient of thin blebs where they go in for an infection, would you take them up for bleb repair?
Yeah, so sometimes what happens is once the infection resolves, the bleb completely scars. So if the bleb scars and then you don't have a thin cystic component there and the pressures have shot up, then of course we are not going to touch it. But if there is a thin cystic bleb, yes.
Okay.
There are studies that have very clearly shown that once they have an infection, the chances of them having a recurrence is extremely high.
Absolutely, yeah. So that's why this particular question I had asked. Usually we tend to, get resolved and then you tend to relax. But these people, they do get the reinfections sooner or later. So it is better that we go and repair these blebs so that they don't get much of reinfections.
Yeah, so one point I would like to add, Satyan, because this is again not uncommon at all. NLD obstruction, blepharitis. Please look for it because this is something that people miss in emergencies, miss even when it goes to the VR surgeons. So that's something very, very important, because there should be some risk factor why this patient has developed the problem. I think that needs to be addressed, and that needs to be definitely ruled out.
Correct. Especially when somebody has a thin bleb and an NLD, then I mean CDC, then they have a very high chance of getting infected sooner. So the Manish and Sushmita, Devang, all of you are there. If you have any questions to ask, please do ask. I think the questions can be both to Dr. Sirisha as well as to Dr. Sushmita, both of them. If the time is short, you can have 2-3 questions and then we'll close it.
Dr. Sirisha, thank you for a very nice presentation, ma'am. I would like to ask one question, that if a patient is in stage 3A and you have given an intravitreal, how long will you wait, or how will you consider for the second intravitreal? What are the factors that you would consider?
Yeah, so we typically admit the patient, and then if, let's say, today the patient has had an intraocular antibiotic, they always have a vitreous biopsy also done along with the intravitreal antibiotic, and we review them. Let's say if we've seen in the morning, we review them in the evening again. So in the next 6 to 8 hours, we review, and then we review 24 hours. So if there is a downsizing of the inflammation, and if the vitritis is coming down, or if it is remaining stable, we hold on. We don't give the second intravitreal immediately. We wait for 48 hours before we give the intravitreal antibiotic. But if there is no improvement, or if there is worsening, then of course you take it up for a vitrectomy.
Okay, thank you.
Yeah. Sushmita, you're there?
Yeah.
Yeah. Is there anything you manage differently, or is it the same line you have to follow?
I think our VR surgeons are a little more aggressive, and if they don't see a response in 48 hours, they would like to go in. The usual thing is they wait, they have to see a significant thing getting better, either visually or the media or ultrasound or something. But if it's status quo, I don't think I mean, ours think that bleb-related endophthalmitis are far more dangerous than post-cataract surgery endophthalmitis. So
Talking
they're a
about,
little more aggressive.
so you're talking about a 3 or stage
Yes,
3 or
even
3B
before that,
only?
if there is correct, if there
Okay.
is no improvement, then it's an indication to go in. They would let us get away with one intravitreal, but they're more scared of bleb-related endoff than post-cataract surgery endoff.
Okay. Is that the patient who has IOL done has more chance than those with the phakics? Do you have any change in the way you manage? Because
I'm not sure that there's any difference in the two. Actually, it is quite rare. So making a one-off judgment whether or not it's not. I wouldn't be able to give a definite.
yeah. Sirisha, if the blebitis is just restricted to the bleb area alone, do you feel there is a role of doxy? It is for all of you.
Doxycycline in a bleb-related infection, I'm not quite sure.
I'm not saying it is say confusing stage whether it is an infection or is it just a blebitis. So do you feel there is a role for
Oral doxycycline, I don't think so.
all right? It is basically
we
for
give
more
it-
scar tissue formation.
Yes, it's only for healing, at least as far as we are concerned. In glaucoma, we use that to prevent collagenolisis, and that should be in the early healing phase.
All right, Manish, you are there?
Yes, I am here.
Yeah.
So that is okay. Doxycycline, I think in patients who are come with an infection, you are going to give oral antibiotics also. So you are
So fluoroquinolones is what we normally give, oral antibiotic. And like if somebody is sick and unwell and things like that, then IV antibiotics are also given. But otherwise, doxycycline is bacteriostatic, and the dose that we give is not anywhere close to what can help. So that's not used as an antibiotic also. So it's usually fluoroquinolone that we give.
Manish, do you have any questions for Dr. Sushmita regarding the OCT, or do you want to add some points?
no, I'm okay.
So can I ask one
Yes,
question?
yes, Devang, please.
So this is for all of you, ma'am. You had a very nice presentation, ma'am. One thing that you had mentioned about temporal raphe sign. So how often do you see it to be symmetrical, or how often do you see it to be asymmetrical?
Well, depends on the symmetry of the glaucoma, really. I mean, like you have asymmetrical glaucomas, advanced in one and early in the other. So that's how the temporal raphe would be. It's depends on how much of ganglion cell loss is there. But of course, the temporal raphe is not until the ganglion cell comes within the measurement circle. If it's outside it, you might not see it, but there's still glaucoma. I mean, absence of temporal raphe sign does not rule out glaucoma. That's what I mean.
Yeah. So, thank you so much. We have just exceeded our little bit of our time. And thank you so much, both of you, Dr. Sushmita and Dr. Sirisha, Dr. Manish, Devang, Devan, everyone. Thank you so much for being with us today. And we'll move on to our webinar tomorrow again. We have for the full week. Please do attend, and everyone are so important. They give us such a wonderful talk, so important for our day-to-day practice. Thank you all once again.
Thank you.
Good night. We'll see you
Good
tomorrow.
night. Bye.
Thank you. Good night. Thank you.
Right.